Now moving on to our last section, that is the neuropathic tarsal disorganization. You know by now that the mechanism is such that it's only peripheral neuropathy, that there is no nerve supply to the muscle, to the ligaments, and as a result, the ligaments are unable to actually send back to the signals in form of what kind of a pressure is actually occurring at this joint. This eventually leads to tarsal disorganization. This could be aseptic or septic. Aseptic disorganization includes mainly it's due to the inadequately treated fracture, that there was some kind of a fracture but this resulted in ligamentous disruption, but despite the close reduction was done which was not improperly done, this leads to aseptic disorganization, that the tarsal bones are poorly organized due to loss of actually capsules and ligaments around them. This could lead to mild pain and swelling and tenderness over the foot area, especially with the dorsal surface of the area. And X-rays usually show necrosis and disorganization, that there is increased joint space between these bones, and they may be oriented in a 3D plane differently as compared to normal X-ray of the foot. Now, the treatment includes avoiding the weight bearing in the movement. They may have to be kept in non-weight bearing for a few weeks. Usually enforced bed rest may have to be done as well. This could also mean that total contact cast have to be given to these patients so that it takes at least 4 to 6 weeks for them to heal properly. Once the ligaments heal, they can restart their walking like normal function. This could be in form of walking cast can be given as well, so that they can still keep on doing their daily activities along with the casting. Sometimes even after the cast is removed, there is always some degree of problems left, which can be treated with appropriate orthosis, so that the patient can carry out his or her living along with the orthosis being worn for most of the period of the time of the day. Or if it's it's more problematic, or if it has actually degenerated, or there's evasion of the bone or of any of the tarsal bones, this may would eventually require some kind of a operative stabilization. Or tendon transfer may have to be done so that the normal gait mechanisms can be restored. Other problem is septic tarsal disorganization. This is due to the sepsis and actually which has occurred over the tarsal area, which has causes the necrosis of the ligaments and the joints, and eventually leads to tarsal disorganization, which is mainly septic. This causes called the infection, which is spread from the plantar tarsal to the tarsal bones. Foot may be immobilized in a blow knee cast, but we have to remember that if there is some kind of an abscess or a wound, an ulcer, then we may have to go surgically to debride that and then give them total contact cast. But if it is actually there is no frank ulceration and frank pus coming out, then we can give systemic antibiotics and keep the foot immobilized in a blow knee cast so that it can be given time to heal over the time. Then bony, if it has actually spread over all the tarsal bones, then bony fusion or orthosis is always the last option, so that the patient can get rid of the pain which is usually associated with these problems. So, thus bony fusion also helps to give it a stable rigid foot, which is actually required for the normal gait mechanisms. Usually the treatment is surgical stabilization after clearing of infection. Now coming to the amputations. As I told you, in neuropathic foot, especially with the case of leprosy or in diabetes mellitus, usually what happens is this insensate foot, this leads to continuous problems such as trauma, minor trauma, cuts and fissures develop. Patient has no pain, so patient is unaware. This leads to some kind of seeding of street bacteria into it, eventually leading to ulceration. Usually these patients, when they come, there is not only simple ulcer as well, there is always a complicated ulcer which is associated with osteomyelitis of the tarsal bones or metatarsals as well. Therefore, sometimes we have to go for amputation as well, because the bone and the soft tissue is necrotized to a level that it cannot be salvaged. Therefore, we may have to eventually move towards amputation. Therefore, different type of amputations are available. In case of the foot and ankle, it could be simply metatarsal disarticulation. If infections and necrosis and gangrene is restricted to that, this could be in terms of metatarsal disorganization. If involving the metatarsals along with some part of the tarsal metatarsal area, this could lead formation leads to reamputation, in which all the phalanges and some part of the metatarsal is removed. Other option is transmetatarsal, that is that simply removing almost half of the tarsal head and neck can be removed and only some part of the body is actually saved. This is called as transmetatarsal amputation. Usually this offloads most of the forefoot. If there is involving most of the forefoot gangrene, then we may have to resort to this kind of amputation. Other amputation was actually the Les Frank, the Chopard. Les Frank was a French scientist who actually devised this amputation. There is a Les Frank ligament which is actually at the junction of the tarsal-metatarsal joint between the first and second metatarsals, and this was is named from the name of the Les Frank because there is a tarso-metatarsal disarticulation, that where the tarsal ends and the metatarsal starts, this is disarticulated at this level. And usually in this case the forefoot is disarticulated, midfoot and hindfoot is remain intact, and then this can be used for shoe wear as well. The last is about the Chopard amputation. This is Francis Chopard was actually the scientist who discovered this, and this was actually the transtarsal amputation, in which this is the actually only the talus is spared, but all the tarsal bones are removed. And usually, what happens is the forefoot and hindfoot are forefoot and midfoot are amputated, and hindfoot along with the talus and the calcaneum only remain. And this is usually if the infection is severe enough that it's involving the forefoot bones and gangrene and midfoot bones are involved as well, along with osteomyelitis, then we probably may have to go for the Chopard amputation. Then there is another type of amputation called as Simon Boyd, which actually breaks some part of the hind foot is also removed. Now, this is a kind of a clinical decision which is to be done by the clinician on the duty that whether this tissue can be salvaged or not. Do I need to give only antibiotics? Do I need to do debridement only, or I should be going for the amputation? So as I told you, it's actually the shift problems to the proximal level. That if the problem is at this level in the forefoot, we can do the amputation, and the load is actually shifted to the midfoot and the hindfoot. This is usually sometimes prosthesis is available. For example, baloney amputation is if it's done for the certain problems, then we can have a prosthetic leg, which is very much reasonably good option. Principles of the amputation involve amputate only if you must. That is, we should not be there is not be judicious use of amputation. Amputate conservatively. Try to preserve as much tissue, as much bone as possible. But this is very tricky over here, that we have to understand that we cannot keep the dead tissue there. We have to remove all the necrotic and dead tissue out. And if we are thinking that this muscle and tissue is dead, or it at least will be dead in few hours, then we may have to amputate it as well. So try to provide an end-bearing stump. So if I, for example, in case of Syme or Boyd amputation, although it's actually good amputation that you don't need a prosthetic with that, but the problem is then there is continuous ulceration despite the patient is actually not using prosthesis. So we have to understand that we have to give that kind of an amputation, but it's also energy conservation is there as well along with this amputation, plus patient is able to carry out his or her daily activities after fitting with the prosthesis as well. In this section, we have briefly gone through what are the complications of tarsal disorganization. It could be aseptic or septic. Aseptic is associated with inadequately reduced fractures. Septic is actually associated with basically the plantar ulcers, which eventually the infection spreads from the plantar surface up to the dorsal surface and may require some kind of surgical stabilization. Usually, when they has advanced ulcers and infection is advanced, it reaches the dorsum, we may have to eventually go for some kind of a surgical procedure which involves a bony procedure, and so that the bony stabilization can be done for the plantigrade foot to occur. I briefly went through the different types of amputation. And the principal amputation as well, that it could be a simple ray amputation that is involving the phalanges and some metatarsal head. It could be transmetatarsal, that is involving through and through the metatarsals. It could be a less frank, which is tarsometatarsal level, in which the forefoot is actually removed and hindfoot and midfoot remain there. Or it could be a Chopard fracture, in which there is a transtarsal amputation, that this only hindfoot talus and calcaneum are intact and the forefoot and the midfoot is actually amputated. Keep watching sqadia.com. Thank you very much.